Okay, welcome everybody to 2022 to the Miami Global Brain Tumor Symposium. Very, very excited to start off the year with some excellent talks tonight. But first I wanted to say thank you to all of our speakers from 2021. It was really another amazing year. We had some fantastic speakers and I think had some great discussions. And there's no question that we had a positive impact on education and patient care by sharing the information that we were able to do with that. And I'm looking forward to continuing this. Thanks for everybody's support and comments over the last couple of weeks and months saying that we should continue, and looking forward to the agenda of speakers that we have lined up for 2022. So again, these are the people who are here at that helped me put this program together. Myself, Dr. Komatar, Dr. Morkos, Dr. Benjamin, all critical parts of our brain tumor team. And I thank them for their support. Also, we couldn't put this together without all the administrative support from both the Sylvester Comprehensive Cancer Center, University of Miami, and the neurosurgery department, especially Roberto and Iggy. Thank you so much for being there week in, week out with us. If you have any questions about our program or about our talks or seminars, you can always find more information on the website. But also a reminder that all these are logged and categorized on our YouTube channel for University of Miami Neurosurgery. And please go back and watch them. And it's a great learning tool for everybody. Quick preview for next week. We'll be welcoming Dr. Prada from Italy. Francisco has been really a key player in pushing focused ultrasound forward. Has been doing a lot of great work with Dr. Sheehan and UVA group recently, and is going to bring us up to date on where we are with ultrasound for brain tumors. So stay tuned for February 2nd's talk. And again, just a summary of our seminar tonight. Please use the key and button. We want to make this as interactive as we can. It's an exciting topic tonight, and so we're hoping to generate a lot of great discussion. We don't offer see me, and then please be sure to like, follow, and share our videos on social media. So tonight we have a great group of guest speakers tonight. Dr. Hamp joining us from New York, Section Chief of Neurosurgical Oncology for Westchester Medical Center. Dr. D'Amico, Director of Neurosurgery at Wyckoff, associated with Lenox Hill, and is doing a brain tumor and skull-based work up there. Dr. Higgins and Dr. Cater are both brain tumor fellows here at the University of Miami and help us every week, day in and day out in our clinical aspects, and we thank them also for joining us today. Today I have a great speaker, Dr. Patel. He's one of our own. He's one of our fellows this year, but he's done just a tremendous work thus far in his career. You know, Nitesh graduated early. He did the combined 7-year program at Rutgers, finished early, went right into medical school, won a ton of awards, already started with his neurosurgery research while he was there, as he knew he wanted to be dedicated to that, and continued on at Rutgers in the residency. He's published over 70 papers in his time thus far. That was mostly before he met us, and since he's been here for the year, he's also added to that considerably. Several different awards. He spent a year at Lenox Hill doing a fellowship on brain tumors, and then came down here to Miami to do another fellowship with our group, and has just done a phenomenal job in the OR, out of the OR, teaching the residents, and just helping build some of our key protocols for helping our brain tumor patients. And one of the protocols that I think he's really passionate about is helping with patients and their postoperative care and follow-up care. And he's going to talk to us a little bit about ERAS. I should also note that he has a major impact on the tumor section for the CNS AANS section, and is also on multiple editorial boards as well. So Nitesh, it's been an absolute pleasure to work with you this year. We're so proud of you. We have no question you're going to be a future leader in neurosurgery, and this is just the first step.
I don't think I've ever had an introduction like that. Thank you so much, Dr. Ivan. Of course, thank you to Dr. Ivan, the rest of the Global Brain Tumor Symposium team for just having me and giving me the opportunity to speak today. And of course, my co-fellows, Mike Cater and Dom Higgins, who've been phenomenal here. And, you know, without them, I'm not able to do anything that I do every day. And I don't want to leave them. I want to work with them forever. All right. Again, thank you all for sort of coming today and giving me the opportunity to speak. I'm going to talk a little bit today about enhanced recovery after cranial surgery. It's something that I think, relatively new to neurosurgery, especially cranial surgery. It gained popularity for spine surgery earlier before it did for cranial surgery, but our work here at UM, it's been phenomenal to see the protocols already in place and the advancement that seems to be happening every day in terms of our ability to recover our patients faster and get them back to what is normal for them. So let me first briefly just go over, the physiologic response to surgery. Patients are asleep, they're anesthetized, but the body still reacts to trauma. Surgery is trauma. And a cascade of events trigger cytokines along with co-regulatory hormones. Muscle and fat breakdown occurs. And this is all an effort to produce energy. Acute phase proteins also produced, which can trigger response to injury modes in multiple organ systems. And this can result in pulmonary inflammation, injury, atelectasis, cardiac stress, along with renal injury, gastric stress, and the surge of the pituitary hormone axis. Not to mention all the medications we often give can also perpetuate these, all these sort of components. So we can use the analogy of a marathon, the finish line being recovery. Standard expected recovery times for the ideal patient can greatly lengthen due to various factors. This can span from multi-organ or system baseline uncontrolled diseases. Furthermore, careful review existing medication regimens is necessary to bring this patient as close to ideal as possible. Sort of that patient who may have a few comorbidities would be in red, as you can see, along with versus a standard patient, completely healthy individual in green. And just the recovery time has to be optimized so you can reduce that red portion before surgery so they can have a more rapid recovery. The goal of ERAS is to preoperatively identify which patients are fit for the procedure in mind, along with its expected recovery. ERAS protocols typically define 3 phases of care in which a series of small interventions can produce big results: preoperative, intraoperative, and postoperative. ERAS protocols have been developed using an evidence-based and multidisciplinary approach. Over the last decade, their use has expanded from general surgery to a variety of specialties and subspecialties. For neurosurgery, our spine colleagues here at UM took the ERAS concept early, as I said before. The visual protocol here is from Dr. Wang's recent paper. And taking any one of these single interventions may not seem like a big difference. Things like just simple things like education and counseling. And people may write that off saying, how much of a difference will that make? But even if these single, interventions can reduce complication risk by a fractional percent or even 0.5%, when you take them cumulatively, you can see that there can be potential for a several percentage point reduction in risk and complications. One key component here is the top and bottom bars of this image here. We should not take for granted the power of continued patient counseling and reinforcement, not just in the office before surgery, but right before surgery and immediately after surgery, including their postoperative, day 1 and day 2 potential time points. The power of this is immense. And on the other side, of course, auditing ourselves, patients, and outcomes is an excellent quality improvement effort. The ERAS approach challenges more traditional models of care. These were often labeled as fast-track methods early on, but the evidence across different general surgery specialties was clear, especially on postoperative hospital stays, many of which were reduced less than half. I mean, you can see inguinal hernia repairs, went from 1-day stays to several hours. And that's sort of how the general surgery literature evolved on this even earlier than spinal surgery did. Our own institution's ERAS data for spine showed strong results as well, as we hoped. Length of stay, Zofran use, opiate use, such as Percocet, decreased across the board. Meanwhile, distance ambulated physical therapy increased significantly. This diagram sort of identifies small but important steps that can sum up to a much larger effect. The red asterisks sort of show elements that can be easily improved, even when the resources are limited. I mean, these factors here can be improved anywhere, no matter how sophisticated the system or not. Even if each of these factors just reduce complication risk, overall complication risk by 0.25%, 11 of them to combine can lead up to a 3% risk reduction. And it is an additive risk reduction. So it seems the ERAS mindset is great to have, but patient selection is pivotal. We assess every patient's KPS. We have careful preoperative medical and cardiac and pulmonary clearance as needed. We correspond with referring doctors, their primary doctors, and any provider who's relevant to their care. And we document all these things so that not just to cover ourselves legally, but to make sure that the entire team that use our EMR is aware of everything going on for the patient. And of course, care is taken to evaluate the role of preoperative embolization for tumors and things like that, additional imaging, et cetera. One important fact here, and this is sort of borrowed from one of Dr. Ivan's talks, is the frailty index. Frailty is a measure of decreased physical reserve affecting outcomes. A Canadian study of health and aging led to the frailty index. And it's sort of a 70-point scale, which has been modified now to a modified version, which is 11-point scale. And it's been sort of mapped from the Canadian databases to the NISQIP that we use here in the US. And it can play a huge role in helping identify which patients will tolerate certain procedures and recover faster versus those that would require more attention. Let's briefly use two sort of logistical sort of timelines here. Here's a sort of standard, a common approach that most institutions may use, and this is familiar for me from my own training before I came here to Miami. For an office visit, for example, you have an initial encounter. Surgery is scheduled for 2 to 6 weeks later, followed by medical cardiac clearance, a workup, additional images during this time. Patient arrives 6 a.m. for surgery, gets her consent, gets IV started. Patients often waking up at 4 a.m. to get there, and also anxious, of course. And then post-operatively, there's standard pain control, there's progressive PT, DVT prophylaxis, has happened at some point, and some places have varying, even intra-institutional protocols for DVT prophylaxis. Some attendings may say post-op day 1, some may say post-op day 5, some may say never. And this can lead to inconsistency. And length of stay, of course, can average anywhere between 4 days, 5 days to a week. And this is for standard cranial cases. At the same institution, urgent, semi-urgent cases may be treated slightly differently with a bit more speed. ER visit occurs, patients scheduled for surgery within the next 72 hours. Rapid medical clearance is obtained from within the hospital. Additional images are obtained. Surgery occurs. And then, of course, the standard post-operative recovery. How do we change this from an ERAS standpoint? Well, when you have an office visit, schedule the surgery as fast as possible. Have a realistic discussion with the patient. Explain to them, look, you're going to have this procedure. Here's where the incision is going to be. You can expect to have some pain and swelling in this area. It is surgery at the end of the day. But you have to ensure that they understand it's going to be a mild headache. They'll have some soreness. If they're having a pterional approach, for example, and the temporalis is going to be cut, well, they should expect some difficulty with chewing or pain afterwards, and so it's not a surprise. You should have rapid correspondence with referring doctors and primary care providers. These are the physicians who are going to be giving you clearance. We admit patients the night before here often for intravenous steroid therapy to help optimize the patients. It also allows for an opportunity for a smoother pre-op and rest. Patients don't have to wake up 4 a.m. for surgery, rush to the hospital, figure out logistics, get here, then get swamped with documents, consents, and clearances, and all these things, along with getting their IVs and medications checked. They can come in the night before, they come in the evening, they have dinner, they have their images taken care of, they get a full night's rest. The morning, they simply wake up, roll down to the operating room, sign their consent, and they proceed to surgery. Post-operatively, we use a multidisciplinary approach. We're strategic in the way that we have our physical therapists sometimes work with patients same day, if not the morning after. Imaging is done rapidly overnight. And this way, patients are ready to go, essentially, from a checkbox standpoint. For urgent patients, same approach. We try to work with the OR to find a reasonable scheduling slot. We rapidly correspond with inpatient physicians because there's oftentimes a patient that came through the ER. And, we sort of have a series of plans, not just the first plan, but a plan B, a plan C, a plan D. And then, of course, our same post-operative sort of approach for recovery. Patient expectation discussion are important. A realistic plan, trajectory of care, potential outcomes, all relatively common scenarios, of course, should be included. So patients are aware of all the possibilities that can happen. We look at blood thinners, we talk about pain control, glucose control, and central spirometry, which these are just 4 basic components, which everyone knows about and everyone is aware of and everyone claims they talk about, but they often go missed, including in central spirometry. And we've all been in this scenario where we're expecting this to be in our order set, and we go to the bedside, it's not there. Blood thinners, we've all been in a scenario where the patient shows up and all of a sudden they have not stopped their aspirin or their Plavix or their Brilinta. Pain control, patients require only a certain amount of pain meds, but they think they need more. Glucose control, diabetics who are not taking care of themselves in the months before surgery. Again, it's like tuning up for a marathon. So I'm going to go over some data shortly, but I want to sort of go over some operative considerations we use here at UM Choosing the optimal approach sometimes requires thinking beyond standard textbook choice. Utilization of one or multiple approaches can have significant value. All these approaches are common to the neurosurgical armamentarium. However, we can review some nuances relevant to ERAS. And it's the little things that can make a difference, make a big difference. It's the little things. So some fundamentals: we use neuronavigation for all cases that are cranial that, of course, would be helped by it. Neuromonitoring is used judiciously. We have it readily available. In fact, we have neuromonitoring towers in every room at all times. We simply need a neurophysiologist if necessary. And then, of course, expected degree of resection has to be kept in mind. And we can think about this in 4 broad categories. Benign superficial lesions, the goal is gross total resection. Benign deep lesions, we want to be conservative. Malignant superficial lesions, the goal is gross total resection, but you got to respect anatomy and function. And malignant deep lesions, well, in that case, we got to think about other options such as biopsy and/or lit and/or radiation in conjunction with each other. We use, sort of 3-pin fixation for surgery, obviously in certain tumor cases, but it's not always necessary. We use the Medtronic navigation system here, which allows for axiom electromagnetic tracking. They're used for our transfemoral cases. It's more than sufficient in a large variety of cases. Pinning itself seems to be benign, but we've all heard of patients mention pin site pain or pin site bleeding. Also, pinning doesn't come without risk. It's rare, but it does not come without risk. For transfemoral cases, during exposure, it's sort of critical to minimize disruption of existing tissue planes unless it's absolutely needed. Excessive turbinate mobilization or takedowns or preemptive nasal septal flaps, excessive posterior septal takedowns, all come with a risk for complications, including mucosal stripping, which we think is benign, but you can ask our ENT colleagues, those patients with excessive mucosal stripping, come back a mess with excessive amounts of pain. This can lead to cardiologist necrosis and resulting nasal deformities, which can be a nightmare. Identifying major vessels is standard, but we should also be aware of CSF pockets in front or behind a tumor, arachnoid folds and clefts, which can avoid, being aware of these things can help avoid a CSF leak, even a low flow one. We use the spyway tubes here, which are great. We avoid you bumping into tissue on your way down with instruments. I'm going to try to play this video. Hopefully it plays. And I'm going to sort of zoom through this here. But there's sort of rigid meshes that can go right into the nasal cavity and allow for easy access in and out without bumping into mucosal structures on the way in. Some other operative considerations, tailored craniotomies. The workhorse craniotomies, working corridors were created before advanced navigation was widely available. They're all standard learning for all neurosurgeons, of course. But neuronavigation allows for tailoring these craniotomies. We can modify them. Specifically, areas of potential morbidity, such as the frontal sinus, orbita, periorbita, mastoid air cells, venous structures, all can be carefully mapped. The pseudo exception is when there's a high likelihood that a degree of brain retraction is necessary, in which case care should be taken to maximize cranial opening without getting into previously mentioned areas. This can decrease chances of delayed venous injury. Sort of when you're trying to reach for that little bit of tumor under bone and, you think that you can just retract the brain, but that can lead to delayed venous injury. The small vessel can tear or get obstructed. And this is sort of more relevant to frontal area meningiomas that are deep. And sometimes a transcortical approach is necessary. It may not seem like the first choice you'd think of, but it may be the safest way to avoid further complications for the patient. Some operative considerations, trivial retractors allow for reach of deep-seated targets. They're thought to be as fiber tract splitting, but it's more than likely that there's a degree of cortical and subcortical injury. However, in contrast to traditional paddle retractors, force is applied circumferentially and retains a cone of work. Obviously not the solution for everything, as trajectory change is a challenge, maneuvering the tube around, but it does allow for smaller craniotomies, of course, and therefore smaller incision. Here's an example of a case that we did entirely through a tubular approach. It was a fairly massive tumor with discharge home the day after surgery. The patient had their surgery, spent that night in the ICU. The next morning they have breakfast, work, physical therapy, and they're home shortly after lunch. This is all through our ERS protocol. Stereotech needle biopsies, common neurosurgical procedure, common practice. We've standardized use of robotic guidance as it gives consistent sub-millimeter accuracy no matter the operator. It also allows for the biopsy catheter to be rapidly swapped for a laser fiber if necessary. All of this can be accomplished using a 2 millimeter burr hole and incision. Patients are often discharged home the day after surgery Additionally, since the incision is 2 millimeters, a single absorbable suture can be placed close to close the incision. When biopsy and lid are combined, it's quite the powerful combination you can have for treatment. That's sort of the algorithm that we think about and keep in our minds when we're in clinic making decisions. For transcortical approaches, of course, the shortest distance is key. Navigation, is most useful until a lesion is encountered. Sometimes a tubular approach is not feasible, and therefore a transcortical approach is needed. To minimize cortical injury and disruption, we choose the shortest distance through the least eloquent cortical tissue. Key moves here that contribute to the ERAS protocols are avoiding excessive bipolar use once or about 1 centimeter deep, noting PO banks, and being mindful of sulcal boundaries. We avoid taking vessels in general, especially veins. Venous anatomy is often less predictable than arterial, and this means that what may seem like an insignificant vein may lead to delayed venous infarct and disastrous results. Awake craniotomies is another option here, and most institutions, it usually triggers the attention of anyone, including patients, of course. Awake craniotomies in most places are an event. It must check with anesthesia, neuropsych, neuromonitoring, nursing staff, even before considering standard factors such as patient tolerance, positioning, stim plans, and testing. But volume is what leads to efficiency, and volume is everything. We do a lot of awake cases here. We essentially consider it an awake approach for any primary brain tumor in or near high-end real estate. Upon finishing the bone work, we alert anesthesia to wake the patient up so that by the time door is open, we can proceed to testing. Awake approaches allow for faster anesthesia recovery, better anatomical functional outcomes, and of course, shorter hospital stays. And here's a famous case from Dr. Komatar's social media post. Hopefully, you guys can hear the audio.
Go for it, Matt. Touching hands. Reaching out. Touching me. Touching you. Sweet Caroline.
So you can see the patient here, of course, our team on the other side of the plate.
So good, so good.
And it was a good way to map language and, ensure that the patient's function was preserved. Operative planning, of course, positioning is critical. We try to limit stress on the patient's neck and shoulders. And this can make a big difference, especially during, positioning. It's key to keep this in mind. Good use of bumps and positioning devices to maintain as neutral body position as possible. We try to always approach cases supine, but if not, reasonably normal anatomic alignment is key. Of course, surgeon access and position are also important, therefore should be balanced. But one thing to think about is, having a patient with their head turned and their body and going in the other direction for several hours is going to lead to some soreness, and that's going to play into a factor of how the patient feels after surgery, and how motivated they are recovering and going home on time, as opposed to sitting around in a hospital and increasing the risk of complications. Staples can be your best friend. Something to keep in mind. Great to keep big chunks of hair out of the way, and also they can be easily removed with minimal trauma. Some incisional planning, hidden incisions are always ideal. We try to minimize hair shave to almost none. The temporalis muscle is often encountered in the trajectory of frontal and temporal approaches. We avoid making cuts as opposed to, using a standard terminal approach. Patients often notice this when they're trying to have their first bite after surgery, and they notice all this pain, and that just plays a role in how they feel and how they recover. It's even for small cuts. Just imagine how often we engage our temporalis, right? Eating, chewing, talking. Even a small temporalis injury we felt, and that can make a patient feel sicker than they are. The frontalis branch, of course, should be kept in mind. Especially for these transtemporalis approaches. Bone work, is critical also to keep in mind. Avoiding the frontal sinus, as mentioned, is a key. Each bit of bone should be a real advantage for surgery. It should be a move that counts if you're going to be removing any bone. We try to almost always use a unilateral approach, particularly for bone work. The skin incision may extend across midline, but the bone work should try to avoid it. Even for large anterior skull-based tumors, a unilateral approach can accomplish an equivalent, if not better outcome in some cases. This is where a transcortical route may be advantageous to keep the cranial work smaller. Both of these cases here were done using a unilateral approach. As mentioned before, avoiding bipolar work deep in the surgical bed, especially beyond a centimeter deep. For senior residents who are listening, it's good to slowly develop an understanding of the subpeel technique, of peel banks, et cetera, and its value for protecting sulcal vessels living in the sulcal space. We try to obtain as tight of a dural closure as possible. It's not always possible though, of course, and therefore you may create a scaffold. We utilize a multi-layered approach. We use the dehydrated amniotic membrane, the DAM or amnion, along with standard Durgen or bovine collagen substitutes. And, in our series, this has been shown to provide lower rates of CSF leaks, especially pseudomonagoseals. And this means less of a chance for wound breakdown and or infection. Shown as an example for a recurrent case in which the amnion and Durgen sort of incorporated and sort of created this nice dural replacement that felt and looked just like Dura would have. Barb suture works very well. Its absorbable features mean it can be especially helpful in the telehealth era. And, we're all sort of slowly moving into telehealth being our primary mode of interaction with patients just because of the current circumstance in the world. Some postoperative considerations: anesthesia and pain control on post-op day 0. Make sure anesthesia is aware when bone reconstruction is complete intraoperatively, so they know when to back off the medications. Limit opiate use. The whole team has to be on board. You don't want that one provider who's, there at super busy and the patient's complaining about pain and just throws a morphine order at them. You want to avoid that. And emphasize patients, the pain that they can expect in the postoperative trajectory. Expectations can really change how a patient feels. Have them sit up, ideally out of bed to a chair. Get them to as normal as possible, as fast as possible. Imaging, we're lucky our MRI system here, along with radiology, is fairly rapid. We're able to obtain images the day of surgery, that evening. And it lets us create these wonderful collages or logos that we create. Logos is what we short call it here at the nickname. But we have these ready the next morning, and we were able to send this to all the referring providers. And just imagine yourself being a primary care provider, anyone, a chiropractor, a physical therapist who referred this patient to a neurosurgeon, and you get this as a message to you via email or text message the following day. I mean, it's great correspondence. It clearly it shows what exactly was done for the patient, and it's truly is a way to communicate really fast. Some post-op considerations: standardization of medications, antileptics. You got to have clear indication and endpoints. Steroids, the entire team has to be aware of the dosing regimens. Supratentorial case, of course, eloquent, non-eloquent have different regimens. Infratentorial case have different regimens. Of course, having endpoints that are clear-cut too. You don't want to have scatter, meaning one patient starting a 2 weeks taper, one patient starting a half-week taper. You want to be consistent so everyone can deliver the same quality of care every time. Again, post-op there, day 1, you want to have the patient out of chair for breakfast, sitting upright, eating. You want to have physical therapy, engaged early, and of course, reminding patient of their discharge plan. So they have something to look forward to in terms of getting out of the hospital and having an endpoint. Follow-up, we utilize telehealth a lot these days. It works well for geographically distant patients. We have patients traveling from all over. This allows them to visit from the comfort of their own home. Sutures are often absorbable anyway, so there's no need to worry about that. And, this sort of lets us correspond with the patient and, of course, any provider remotely. Sometimes in-person visits are needed, of course, and this is usually within about 2 weeks. Allows us to review images and, of course, have our other colleagues see the patients as well, including your oncology, radiation oncology, endocrine, and ENT, since all of our offices are nearby. Nonetheless, it's a balancing act, discharging patients sooner versus keeping patients longer. And, I'd like to thank Dr. Ivan for this slide. Taking together all of the ERAS components we just talked about are all aimed at faster recovery and discharge, a return to normal life for our patients. But it's a balance, and identifying how we can optimally balance is key. So, what do we already know? This slide was, again, borrowed from Dr. Ivan as well, and it shows what we already know about the concept of early discharge. This is a series by Shiguru et al., looking at 300 or so patients and discharged within 48 hours. The readmission rates were comparable to standard series, and no deaths were reported about a month and no major complications. So, we saw the feasibility of this post-op day 1 discharge at our institution as well. We did a series on this as well. This is another study with Dr. Ivan in our department, and sought to answer a series of questions. Is it safe? Do patients that leave early have more complications? Are these more severe, more readmissions? Do hospital-associated complications get reduced by early discharge? Nosocomial infections, DVTs, pulmonary embolisms, and of course, can any factors predict patients who can be successfully discharged in post-op day one? How can we predict which patients will do well and which won't? This is our own data. This is some of the data that, again, I got from Dr. Ivan in the department study. And, over 1,100 studies of patients, of course, were examined using this, and 132 of them were discharged on post-op day one. This is compared, with a 5% requirement for readmission. Only 5% of patients required readmission. This is compared to up to 17% readmission rates for larger general series, looking across all cranial surgery patients. For this study, the frailty index we discussed earlier, either the modified or the standard, was strongly correlated to patient outcomes. Patients who scored better on the frailty index did better. Just talking about some complications, for patients discharged post-op day one, straight down the column here, you can see 0 events in terms of UTIs, DVTs, PEs, and the patients that were not discharged in post-op day one had higher incidence of this. So why does this work at UM? Well, patient expectations are set in the office. We discharge patients early, and they're aware they're going to be going early. So they're mentally prepared as well. We're very careful with our approach preoperative in terms of workup. Our neuroanesthesia is dedicated and they also are tuned to the lowest acceptable doses for anesthesia for a quicker wake up, of course. And we normalize the patients. We avoid head wraps unless necessary, minimize hair shaves, and it sort of improves the patient's perception of self and their anxiety level. Physical therapy, we're very aggressive with it. We want patients to be mobilized and back to their normal selves. And of course, our entire team is tuned into this. We took this a step further. We sort of standardized the post-op day one discharge approach, but we also took things even further. The ERS approach for cranial surgery outcomes, nuances that we've talked about, can be applied into novel protocols as well, such as our Discharge Postop Day Zero model. Having brain surgery in the morning and then having dinner with your family at home at night. I just want to give a special thanks to, Dr. Barry and Dr. Morel, both here at the University of Miami, along with Dr. Komatar and Dr. Ivan, along with the rest of the brain tumor team. For certain cranial cases, including smaller cranial convex lesions, we've implemented the same-day discharge system. We're able to do this safely with a multi-team member approach. We've streamlined this preoperative, intraoperative, and postoperative steps, all aimed at getting patients back to normal as fast as possible. And you can follow this algorithm straight down, and we've looked at the last 12 months in which and this number 72, I think, is even higher now, probably approaching close to 100. Our readmission rate was, just about 5%, similar to our post-op day one readmission rate. And I probably has held, I think, fairly solid, if not lower, with the additional patients. Most of these readmissions were for non-neurosurgical things. And, for even 100 patients, 5 patients get readmitted. I believe 3 or 4 of them were just for, non-neurosurgical issues, nausea, vomiting, or UTI or something like that. Well, we're not the only ones doing this, of course. Both of these studies highlight some of the basic inclusion and exclusion criteria. Other institutions are looking at this as well. And, we hope that our data combined with their data can sort of make other institutions start thinking about this as becoming a potential standard or something that's used far more often than it's currently used. I think using this approach, using ERS protocols, can be done anywhere. A lot of the interventions do not require fancy equipment or high-end buy-in from the hospital. It's simply just being consistent. And again, it's the little things. The little things make a difference, and they are additive. And with that, of course, I'd like to thank our brain tumor team here. Here's some pictures of what our lives are like here. It's an awesome experience. It is absolutely one of the best training years I've ever had. And, I'm really lucky to be here. And I'll take any questions. Feel free to message me on Instagram or Twitter as well. But again, thank you, Dr. Ivan. And again, thank you so much for having me.
Great job, Nitesh. We have a couple of question and answer kind of coming in now. This is from Chris Talbot saying, ERS protocols clearly have advantages in resource management and care economy, but many patients will still need inpatient rehab. We were in the middle of another crisis with patient tumors, and we still need surgery. And I worry that we run into acute inpatient rehab bed shortages. How have we kind of encountered these issues? Or how has the pandemic kind of changed our management or of recovery and discharges and care?
It's a great question. And of course, Chris Talbot is a resident currently at Rutgers, who I know very well. We both trained together. Chris, I'll sort of speak to you directly in terms of our experience at Rutgers in New Jersey versus our experience here at University of Miami. It really depends on, obviously it depends on patient's preoperative status in terms of rehab requirements. We both know that. But it also depends on, the patient expectations and, how we approach things. Now, for some cases, you do need rehab. And I agree with you. And that's sort of key. We have to look at these things before we even choose to operate on a patient. Will they be able to get the resource they need after surgery? And of course, the pandemic has affected that. We saw it, when I was still a resident, it was the beginning of the pandemic and there were bed shortages at every rehab around. Patients were sitting around the hospital for a long period of time. But it simply just becomes a balancing act. And a lot of these things are out of our control. But these changes that we make through ERS protocols can help minimize these needs for rehab anyway. Even if you can reduce, let's say 10% less patients require an inpatient stay, that's a big difference.
Yeah, and I just to say too, during the pandemic, obviously resources have been tight. And so anything you could do along your practice to limit the resources, or not limit them, but make them as efficient as possible, will help continue to allow you to provide the care that you need. And so, if we've already streamlined it to a point where, we just need an ICU bed for a few hours, or we don't need an ICU bed at all, that definitely allows us to continue to treat more patients than if the ICU was full, we didn't have access to those beds, and we'd have to just postpone these patients indefinitely. And so we've been able to, this protocol was kind of developed before the pandemic, or thought about and in the works before the pandemic. But there's definitely been times where I think we've avoided shutting down some of the cases that we would have, because we didn't require as many resources as we would have a couple of years ago, when we said, these patients are going to be in the ICU for 3 or 4 days.
Yeah, agreed.
Any questions from the rest of the panelists?
Hey guys, Nitesh, great talk. I guess I'll jump in and start. This is something I've been thinking about a ton. It's something that I'm trying to incorporate here. And it takes a village, right? This starts in your department and with your goals, but it's really multidisciplinary. You have to get physical therapy on board, the other doctors on board, to make sure, the anesthesiologists, your pain doctors, to kind of streamline this. I guess my question is, when you presented the data, you found 1,100 patients, and then you really talked about 100 or so, or 130 patients that met the criteria for post-op day 1 discharge. What goes into your decision making on how you choose the right patient that's going to kind of qualify for this, to be kind of this rapid recovery?
It's a great question. And, I was looking through the frailty index itself, and I was actually introduced to the frailty index by Dr. Ivan. Looking through it, I mean, there's a long list of things you have to check out. Patients who have baseline pulmonary issues, renal issues, diabetics, hypertensive patients, and then of course, those factors can be checked off a checklist. But it's also you can sometimes just tell by looking at a patient of who's going to do well and who isn't, their level of activity, their level of independence. And we've all seen patients who are 90 and independent and living their best lives. We've also seen patients who are 90 and bedridden. We've all seen patients who are in their 60s who are bedridden versus other 60-year-olds who are living their best lives, actively working, et cetera. So that also has to play a role, the physician's perception of the patient as well. And it's sort of, I think, a little subjective. And this goes beyond the quantitative, data you can get in terms of the frailty index and things like that. But I think that there's a heavy component of that where the physician or the neurosurgeon in this case has to look at a patient and be able to tell, with reliable accuracy, of course, if this patient's going to do well or not. And then, of course, the third component of this is just the discussion with the patient, making sure we're clear with patients on what to expect. If they're going to have cranial surgery, of course, should be expecting certain things after surgery. They're not going to feel like their preoperative self immediately. It's going to take time. And I think all three of these sort of trees of things to discuss with the patient or evaluate can really help decide, which patients will do well on a post-op day 1 discharge, or even a post-op day 0 discharge.
Yeah, completely. I mean, the other thing that's interesting is, and I think you kind of touched on this in multiple times in your talk. It's about communication, right? And communication, not just with the family, but their family members, setting expectations, managing expectations early. And we've obviously entered the telemed era, but in addition to that, everything can be app-based or virtual. And so, are you guys using anything specific to disseminate information, to kind of reiterate information to family members? Are you using, apps to communicate, to present these scans to people themselves? Or do you have preset kind of data that you give patients about what they're going to go through?
So I will tell you, at least from my experience in the office when I'm discussing with patients, I sort of have the same discussion with every patient in terms of what to expect, especially when they're sort of let's say intracranial tumor, a non-transplantable case, for example. I tell every one of them, here's the trajectory of care to expect. You're going to come in the night before surgery. We're going to, have you settled in. And the reason why is because I don't want you having to wake up at 4 a.m. to get here. We're going to get you tuned up. We'll get your images. We'll get you checked out, get your IV set up. This way you can have a full dinner that night and have a full night's rest. And then, of course, to tell them about what to expect the morning of surgery, the day of surgery, after surgery, and then the day after that. And when I sort of plan this out, I sort of plant that seed in their mind, and that discussion's had. There's no pamphlet or anything like that, or any sort of digital discussion I'm having with the patient about specifically. It's just a one-on-one conversation along with reminders that are consistent. The other thing that's important here is that the entire team has to have the same face. If everyone is saying the same things to the patient will believe it and will be, on board as well. So aside from that, the only other things that we may be doing from a digital standpoint would be, Dr. Komentar and Dr. Ivan are kind of, freakishly amazing at communicating with their referring providers and the patients. Phone calls are made after surgery and the day after surgery as well, to the patient's family members. Images are sent. I mean, everyone's aware of what's going on, what was done for the patient. And it's these simple things that we do anyway, as long as they're done consistently. And I think that's all sort of is the key to making this happen. Dr. Ivan, if there's anything else that I'm missing or anything else that you think would be worth mentioning?
No, I mean, I would just say that, just to reiterate, it's a team aspect, and everybody has to be on the same plan. Otherwise it falls apart. There's so many reasons why patients stay in the hospital too long. And, it just takes one cog in the wheel to kind of mess that up, whether the MRI gets delayed or physical therapy doesn't get to the patient till after, like, late afternoon, or, the transfer order was placed and the discharge was supposed to be after transfer, or something weird like that. But if everybody on the team understands this is the goal, it tends to happen. And the other point is that you also brought up too, is that this is not for everybody. When you say 1,100 patients and only 150, I mean, the percentage of patients leaving on Postop Day 0 and 1 has obviously been rising as we get better and better with isolating it. We don't have a strict protocol of exactly who fits that just yet. We've been trying to work it out, and there is still a large part of kind of the physician's experience to kind of figure that out. It's not just people who are intact, supratentorial tumors that are less than a certain size. There's a couple comments here. Mohammed is asking, is there a size cutoff for the tumor? Is there, do patients, can they have a deficit pre-op or post-op? It all depends, right? If somebody comes in and they're wheelchair bound before surgery, but they have everything at home already figured out on how to deal with being wheelchair bound, because that's that they've been living for months, then post-operatively, that's their status. They know how to survive, how to live, how to do quality of life in that status. So they don't need to go rehab for a couple of weeks afterwards. They already have a system up. We get physical therapy to see them at home, and they can continue. But obviously, people who change with their function post-operatively, we're not just sending them home without their supportive care. Those people are still staying and getting rehab. As far as the post-operative communication, I don't know if Natasha was going to comment, but we are dabbling with some automated text messaging and kind of alerts to remind patients what to do, when to do it. But I think more than not, doing these studies and kind of analyzing your own data ends up highlighting where the deficits are. So if when we looked at the 1,100 patients, we said, okay, well, why are these 5% of people returning? Are they UTIs? Are they non-medical? Are they medical? And then how do you then adjust your protocol? For the pituitary patients specifically, we just finished kind of looking at our data set, and we've had a whole new protocol in place for the last 10 months of how to address postoperative care to try to get them to more of a a post-op day 1 or 2 for pituitary patients, which is a whole nother population not included in this database. But you need to build up a whole separate protocol for communication postoperatively because it's a whole separate issue of problems.
Yeah,
Absolutely. Yeah, for pituitary patients, especially with the electrolyte imbalances and monitoring these things. I mean, that's the key. It's figuring out a way to do that reliably.
Yeah. Simon,
Well,
any
speaking about-
thoughts?
yeah.
Oh yeah, Mike, go for it.
Well, you're just saying having these automated text messages go out to patients on a regular basis. I wonder if using that, we could look at whether patients are actually happier being at home, earlier rather than staying in the hospital with extra care. I think that would be another selling point, especially nowadays when a lot of times patient families can't be in the hospital at all to be with their loved ones, after surgery.
Yeah, we used to always tell patients, oh, you don't want to be in the hospital, you're gonna get infected. And in the past, that was always kind of like, people would be like, yeah, it sounds bad. But now with COVID, it's becomes much more of an obvious conversation to have with people. And people, I think, have really begun to listen to that idea that being in the hospital is risky. And if there's a safe way to go home, and you qualify for that and you check the boxes, then that's advantageous to you and your family. Simon, you were going to say something?
Yeah, sure. First of all, great talk, Nitesh. I think, for the audience, what Rick Komatar and Mike Ivan have really done with ERAS in Miami, I think is about as cutting edge and kind of pushing the envelope as it is. A lot of kind of pioneering, innovative stuff that has had a huge impact on my own practice and what I do. And it's just highly effective stuff. And you guys really should be commended for this. One little contribution I'll make is that, and this has basically been hinted at throughout the symposium here, is that there are really kind of two paths when it comes to the ERAS. There's the path for the patient that's largely been discussed here, who's kind of almost a setup for leaving same day or the next day, the healthier patient, the supratentorial smaller tumors, what have you. And then there's an ERAS that I put into play for patients who are going to end up going the rehab route. And there are a set of things that you can do to really grease the skid, so to speak, for those patients. And they're kind of somewhat boring things that you think as a neurosurgeon you should be kind of above. But if you don't engage things that have been discussed here, for example, physical therapy, social work, you are going to find that your patients end up staying much, much longer than you think they should be in the hospital. And I won't bore the panel or the participants here with information like that, but basically suffice it to say that getting that early PT evaluation, making sure that that note is in the chart, making sure that social work is actually going to follow up with the insurance company and the rehab facility of choice can shave days off of these hospitalizations. And you as a surgeon at the end of the day will come across in multiple people's eyes as being heroic, not only for the patient, but for the institution, as you're shaving down these LOSs and getting these patients out quickly, and utilizing the resources appropriately, especially, with COVID looming. And so I think that that's also an interesting thing to think about. One other thing I wanted to throw out there that I kind of stumbled into, it wasn't really my idea. I'm wondering if you guys are doing any of this in Miami, but I have an anesthesiologist here who really likes doing scalp blocks really for any supratentorial case. And initially I was a bit annoyed because it added like 15, 20 minutes to the procedure and my incision time was getting delayed and all this. And of course, this is anecdotal at the end of the day, but still, I am finding that patients are waking up much smoother. I'm finding that the opioid requests are less, and I'm finding that it is making good on this hope to get these patients out the next day. I'm just wondering if that's been incorporated, because that's something that this anesthesiologist kind of brought to my attention. And I was really only using Scalp Blocks, obviously, for the awake craniotomies, but these are for general anesthesia. And it's also reducing the amount of anesthetic they're getting intra-op. So it's checking a lot of these ERAS boxes. And I've only been doing this really for, I would say, the past 6 months here. So I'm wondering if that's something you guys have looked at.
think, for our weight cases, of course, as you said, scalp blocks are just standard, but I don't think we have necessarily a formal scalp block, protocol in place, aside from what we injecting Lido into an incisional area, but
Right.
we do sometimes inject the pin sites, which is not uncommon, but nothing like a formal, neuroanesthetic based block that, and I saw some of this in my residency where for our weight cases, we'd have our neuroanesthesiologist would do our blocks. Like Chris Fjeltland, Simon, if you remember, he would do blocks for us. But we, aren't doing formal blocks here for all cranies, at least from my knowledge.
This is something in the literature, Simon. I've seen it a bunch now as I kind of review this, as I design the protocol here, where for awakes or not, if you're putting pins in the head, some people prefer just a local at the pin site. Some people do a full scalp block.
Yeah.
And, I've been going back and forth in my head about it. It's actually good to hear your story about whether or not it's worth the time and effort to do this or not. In training, obviously never saw it once except for an awake craniotomy, and that was just a pin site injection. But I think if you're having a good result with it, I'm willing to try it, because I think the benefit there, you're right, Nitesh, and you commented on this. People complain about pin site pain, right? And they complain about, temporalis muscle pain, which may or may not be covered in the block, but I think pin site pain and incisional pain is real.
Yeah, for some of the other ERAS protocols for, especially for spine surgery, that's a huge component of what kind of lidocaine or injections, with liposomes or whatever they're kind of adding them to make it more long acting. And so I think it makes sense. Obviously, in some cases more than others. Obviously, I think so. We talked about when we looked at our data, because really not many people are leaving on post-op day 1 suboccipitally, and some of that's obviously because of the pathology. But the other part was because of occipital pain. And so, should patients like undergo posterior fossa surgery be undergoing a larger scalp block, because you're dealing with more of those suboccipital muscles, which tend to cause postoperative headaches more and more. And so that was one of the projects I think we're kind of looking at. The other part, though, is that Simon brought up too is you don't need to wait to start. As a resident, I remember sitting in those social round meetings every day during rounds and waiting for the PT person to say yes, go to rehab, or no, not go home, and you're just waiting there, just saying patient stable, waiting for rehab for PT's decision. And we've definitely moved towards, as you said, to try to get everybody involved, like almost either the day of surgery or even sometimes before surgery. If somebody is going to need rehab or is a high likelihood of getting rehab, it's not like saying that they're definitely going to go, but identifying them and letting the physical therapist know. And we obviously have our own rehab center here at Jackson, we're across the street, letting them know also that this is a patient that may be coming quickly. It's definitely helps speed up that transfer. And the sooner you let everybody know, not just we're waiting for the physical therapist to kind of decide, which is a key component, but everybody along the chain needs to be kind of alerted. You don't need to wait for that final yes or no from the therapist before you kind of let them know. And we've noticed that to have it be a big difference.
This is something I learned. I learned this from Simon very early on in residency. Simon was just in the social work room at all times.
Yeah. Yeah. One of the other questions, I think this is an interesting comment, is, do you see any issues with wounds? Patients leaving early, not protecting their wounds and not covering their wounds, and do you have any special home wound care that we do? Obviously I know what we do here, but I'd be interested to hear Randy and Simon, what do you guys do with your postoperative wound care these days?
Simon, you want to start or you want me to go?
Yeah, I don't think I've deviated much from what I learned in residency and from you guys in Miami. I encourage, so I definitely do not have any head wraps. I totally agree with the kind of, just more than anything, the aesthetic of that. It makes it look like you just emerged from the Battle of Gettysburg. It's archaic and it makes you look like you are so injured. So that's out the window. I think, it's an open to air phenomenon for sure. I encourage baby shampoo use, right, to kind of get them away from some agitating hair products. I'm fine with showering on postoperative day 2. I encourage the patient to keep the wound clean. Patients sometimes freak out about touching these wounds and they come back crusted. They've trapped in stitch abscesses. Once in a while, that actually can then be grounds for a wound exploration or a full-blown infection. So I really emphasize verbally, both in the office pre-op and post-operatively, that they really keep that clean. I have found that to make a big difference. I'm seeing a lot more of my patients, as I've adopted this now the past couple of years, coming in with very nice, clean appearing wound sites, as opposed to when I didn't emphasize that, again, the caking, the scabbing, which I think is a big problem. So I don't encourage necessarily bacitracin or any kind of ointment. Sometimes my patients ask me about that. I'm fine with it. It's kind of a plus minus thing. I care more just about local wound cleaning.
Yeah, I agree with you, Simon. I mean, I adopted pretty much the same practices you guys use. I don't cut any hair. I use absorbable sutures, except in the posterior fossa, I will sometimes use staples still, but supratentorial, all absorbable stitches. And I encourage showering, post-op day 1 in the afternoon, basically. What I find though is no matter how many times I communicated, and this goes back to my question about communication, patients are afraid to shower. They don't want to do it. And so, I really drive that fact home as much as possible. And I kind of reiterate what you're saying, Simon. Tell people that it's better to keep this thing clean than it is to be afraid of it. It's closed, and as long as you're, showering gently, gentle shampoo, scrubbing the other side, let water run over it as much as possible. And the other thing I do is, a chlorhexidine scrub before the surgery's over, before they leave the operating room, so they don't have blood product caked in their hair, things that are going to just sit on the incision itself, And I think those things do matter. Fortunately, my nurse practitioner is obsessed with patients showering, and she's taken this as a real call to duty.
Yeah.
And so she calls patients post-op day 1 and post-op day 7. She reiterates the same things we talked about inpatient, obviously.
Yeah,
I think sorry,
go ahead.
No, go ahead, Michael. I think you were commenting the same thing. I was going to change the subject.
Yeah, no, I've definitely been exposed to, people who have done the full head wrap, people who have stapled the wound dressings on, people who have done tape and watertight tape and whatnot. And I just haven't really seen any significant difference in any of those. And so I agree with the minimalist approach of just putting in something that just kind of covers it, maybe while the patient's literally moving from bed to bed. But then after that, I think it's always better to be, exposed and to be people looking at it, people to be understanding what's going on underneath there, and then to wash it as soon as you can. And so in that regards, I don't think the wound care really makes a difference what day they go home. In fact, the longer you stay in the hospital, the less likely they're going to take a shower sometimes. So
Absolutely.
It's probably easier for them to go home and do that earlier than not.
Mike, how are you guys getting in patients the night before? Do you have any issues with insurance with that?
Yeah, occasionally we do. I think that if a lot of the cases that we have the night before are well, I mean, they're all brain tumors. So if you have, significant cerebral edema and we like to pre-medicate them with Decadron the night before, then it's a pre-medical treatment that really, I think, sets them up for surgery the next day. And then it also allows us to get the most accurate MRI, for functional MRI and DTI tractography and contrast enhancement. And we've definitely had some last minute changes. I think actually Rick had one today that, the MRI the night before changed, and because it was so close, we were able to catch it, pituitary infarct or something like that changes your kind of plan. Well, occasionally we come across an issue with insurance, but for the most part, if you say you're admitting because of a swelling and you need some preoperative care, it's been working for us well.
Yeah, thanks. Listen, I think what you guys are doing is incredible, and it's something, like I said, I'm emulating because I think it's a fantastic thing. And with cranial surgery, you guys obviously open it up to vascular and brain tumor, but I think as the majority of us on this call are interested in oncology, from an oncologic standpoint, it's critical to get patients home as quickly as possible. You do not delay their care. You don't have people. I mean, rehab is its own different thing, but sometimes just setting expectations with the family can avoid rehab if you reiterate the fact that someone can go home and get to treatment faster. And so you guys have really set the bar on this, and I congratulate you. And Nitesh, great talk.
Thank you, Randy. Appreciate it. Thank you guys all for coming along, and it's been a great set of questions from our attendees.
Dom, any last thoughts?
Yeah, Nitesh, great talk. I think it is a nice summary of what our experience has been doing the fellowship and learning. this addition to your practice above the technical aspect of doing the tumor resections, but the looking at the patient as a whole and their experience from start to finish. And to Simon's point, I think another aspect of communication that I think makes the system work well is, not just the team, but who's running the team. So, Rick and Mike are very accessible to the PAs, the NPs, the MRI techs, the OR staff. So any little glitch along the way that could come on that may take hours in a different system to go through channels to get resolved, I think get dealt with pretty instantly. And I think so the hands-on approach from the person that oversees it as well as a critical component. So let's say kudos to you guys in that and the example you guys set for us. I do have one question, and it's I think appropriate for our panel here and Nitesh and I as we kind of transition to our own oncology practice. How do you mentally have that comfort level of doing post-op day 1 discharge or post-op day 0 discharge in your early years of practice? I think there's natural tendency to kind of want to monitor people more in a control setting before kind of releasing them into the their native environment, so to speak. What's your mental process or case numbers or benchmarks that you use to say, okay, I'm comfortable now with advancing it to this level?
It's a great question, Dom. And part of the question, it comes into the fact of why we don't have a protocol for who goes home on post-op day 1, because there's so much of it that's an art, right? Just for instance, if you have somebody that's coming from 3 hours away versus somebody that lives 2 blocks from the hospital, where is that in the algorithm? It's not, right? And so, or where is the person who lives with an MP and a PA at home versus somebody who has no family members or who is living with 2 older people who can't care for themselves? These are finite things in the algorithm that are so hard to kind of put in there, that you need to have a really good, keen insight into your patient, their support system, their lifestyle, their family, and taking them in as your own. And if you treat them as your own family, I think you'll get a good sense as to sometimes how it is. The other part of your question is when do you feel comfortable with your care, your accuracy as a surgeon, your postoperative complication rates, to kind of start making those decisions. And yeah, I think there is a learning curve with any kind of surgery. Obviously, those who do fellowships and who get to have a large case volume, that learning curve is much shorter. But I think all of us here are, could talk about our learning curves and how long it took us to feel comfortable with different kinds of things. And it's different for every kind of tumor. So it's not an easy answer to explain. A small right frontal met, I don't think, and you get the postoperative scan, it's clean, you probably wouldn't think about it too much. But your first acoustic or your first, big, posterior fossa meninge, yeah, you're going to think about that for a couple of days and want to sit on them in the wild until you really get a feel for some of those more challenging tumors. Anybody else want to comment on that? That's a great question.
Yeah, I think, it really is a good question. I think as with anything, you probably start a little bit slower. You're not going to probably take some of the chances in sending people out post-op day 1 or 2 with some of the bigger tumors initially. You kind of want to find that comfort zone. I was so kind of galvanized by my experience at Miami, working so closely with Rick and seeing this, that I erred on the other side initially. I was telling people they're going to leave the hospital today. I remember telling a 70-year-old with a massive medial sphenoid wing that she'd be home the next day, Komatar style. And I was just like, yeah, no, that didn't happen. That wasn't close to happening. So I had to almost kind of bring myself back a little bit, because you get so swept up in the, in the eagerness of achieving that goal. So you almost, especially since you're seeing so much of that, you'll probably, the pendulum will have to swing a little bit the other direction, and you'll kind of build, because, and also they'll be built, you'll see the mistakes you made. You'll know that certain tumors require more of that observation than others. But yeah, I would probably say, it's a little bit more of a slow build.
I think, just my contribution to this is set the framework for everyone to accomplish this. And that way, if you look at them post-op day 0, post-op day 1, and they're perfect, everything's in order to go, right? And so have these discussions the minute you get somewhere, and make sure that everyone's on board, because you're going to know, right? Post-op day 1, you're going to see someone, you're going to be like, this guy's ready to go or not. And that way, everything's done, right? The MRI is done. Physical therapy's had their evaluation. You know, you've talked to the family. Everything the doctors have been communicated with, so you have follow-up outside. And if they stay an extra day at first, it's not a big deal, right? It's safe. You're doing the right thing for your patient, but at least you have this, you know, you've kind of got the training wheels on. Everything's kind of set up, right? And then when you're ready to go, you take them off.
And I think that is a key point, is that you want to kind of get the protocol or the engine going, so that it's your decision whether or not to send them home. It's not the decision of, because, oh, we didn't get the physical therapy, oh, we didn't get the MRI done, or oh, we didn't get this done. If set the system up so you could achieve what you want, but and then leave that final decision to their clinical decision only, and then you'll be able to capture that small group of patients that can get advantage from this.
Great. Thanks, guys.
Thanks,
Okay,
everyone.
great. Well, you know, let's see, one more question. No, we're good. So great discussion tonight. I think that this is extremely applicable to everybody's practice at all stages. And I think it's an understated topic. Brain tumor patients are extremely complex, and they're all different, which is why I love this field. And so, you know, treating everybody differently, but at the same time, understanding what is the guidelines and what are the expectations that you can have are key. So anyway, I want to thank the panelists. You guys are all great comments tonight, and obviously Nitesh, great talk, and looking forward to seeing you guys back in the future.
Thanks, everyone. Take care.
Thanks so much, guys. Yeah.
Thanks a bunch. See y'all soon.
Stay safe. Bye.
Bye.